All right, good afternoon. I'm going to be talking about endovascular management of thoracic and thoracoabdominal aneurysms, both sort of current practice and where things are heading into the future. In terms of some background on thoracic aortic aneurysms, they're obviously a fairly morbid condition. 2 to 5 year survival ranges in terms of natural history, depending on the size of the aneurysm, ranges between 13 and 24% for larger aneurysms. And of those treated non-operatively, about 50 to 75% ultimately die of rupture. In Cambridge's series from a few years back on non-operative management, there was a 39% 5-year survival for these patients and a 17% repair-free 5-year survival for those who ultimately stayed with non-operative management. And so, clearly this is a major problem for patients, and our threshold for repairing thoracic aneurysms and thoracoabdominals is a little bit higher than for infrarenals, not necessarily because they have a lower rupture risk, but because the operations are so morbid. So endovascular therapy has dramatically increased the number of patients that can be offered therapy. A lot of these patients we treat with TAAs now are ones that really were not included for operative repair because of their comorbidities, which have become less relevant with endovascular minimally invasive therapy. That said, just because these procedures can be easy doesn't mean they can't be fraught with problems. And a simple descending thoracic aortic aneurysm can be about the easiest case you can do, but the difficult ones can evolve into disasters very quickly due to iliac access issues, strokes, and things like that. So it's very important to look at the aneurysm, but also look at the patient, the frailty of the patient, access issues, and those sort of issues, those sort of things, and really anticipate potential complications or problems. The most important issue, I think, to consider in terms of complications or access. These devices generally are larger diameter devices, require larger sheaths, I should say, than those for infrarenal repairs. So our access issues are a real concern in a good percentage of these cases. Probably about 25% have some access concern. So you need to anticipate need for conduit and that sort of those sort of ways around some of these iliac problems. Patient history and risk factors are obviously important. You do need to stratify these patients in terms of their cardiac risk and keep in mind their cerebral circulation and stroke risk or stroke history. And then the other important thing to consider is a risk of paraplegia. This is much lower with endovascular therapy, but it's not zero. Much lower than open, but not zero. And so things like prior aortic surgery, subclavian artery involvement with likely coverage of the subclavian artery, occluded hypogastric arteries, or large coverage areas, large coverage zones. These are all things to think about when anticipating paraplegia and related complications. Preoperative preparation is crucial. This is more so, obviously, with increasingly complex procedures, fenestrated procedures, where you use a large variety of wires, devices, stents, etc. You also need good imaging systems. These patients are often obese, even when they're not obese. The chest is harder to image than the abdomen in most cases. So without fixed imaging, you really have some poor visibility of what you're doing. So fixed imaging systems are really, I think, paramount importance here. You obviously need an array of catheters, wires, adjunctive devices, et cetera. In our institution, we do these procedures in a sort of a hybrid cath lab scenario where we have both the OR team and the cath lab team. And most of the time, we don't need our OR staff, but they're there in the event that we do have to open a patient, do a retroperitoneal exposure for a conduit or something of that nature. And having the right, any of you guys have done these procedures on an emergent basis with your sort of late shift crew or midnight crew in the OR knows that these procedures can go very smoothly with the right team and very poorly with the wrong team. Skill set of the operator, obviously that matters to some degree, maybe not as much as some of these systems issues for the more straightforward cases. And then preparation in terms of need for preoperative interventions, such things as subclavian artery revascularization in elective settings or spinal cord drainage. In terms of the preoperative case planning, anatomic issues are very important. The first issue for your average descending thoracic aortic aneurysm is the issue of proximal and distal seal zone. You need ideally a 2-centimeter seal zone, both proximally and distally. When you compromise on this, you can expect to have poorer long-term outcomes, just as has been seen in infrarenal aortic aneurysm repair. Issues like aortic thrombus within the neck of the seal zone, these are concerning both for embolization risk as well as long-term seal, risk of type 1 endoleak. And then, as I alluded to earlier, iliac access is one of the biggest issues that plague our success with these procedures. In general, you want diameters, iliac diameters of greater than 8 millimeters. minimal degree of occlusive disease, especially calcified occlusive disease, and minimal iliac tortuosity. One or two of these issues, maybe by itself in moderation, is not a major problem, but when you add multiple of these factors together, that's where we really have trouble, and we really should consider using a conduit of some sort. Concomitant common femoral artery disease is important, especially as we do most of these percutaneously now. Patients with a lot of common femoral disease maybe are better candidates for an open cut down and some degree of an endarterectomy. In addition to iliac issues, aortic tortuosity, both in the paravisceral aorta as well as in the thoracic aorta, can really affect our ability to deliver these endografts to the proper area. And the knowledge of the cerebral circulation in terms of the completeness of the circle of Willis and concomitant carotid disease and vertebral disease is important. I already kind of discussed this, common femoral artery, percutaneous versus cut down. Majority of these are done, at least at our center, with percutaneous access. There are select cases where we know we need to do some work with the common femoral, and then we'll do a cut down for those. With iliac artery disease, the first step is to decide if you think preoperatively you need to go straight to a conduit, or if it's one of those marginal cases, do you think dilators will work? And I do use the Cook dilators routinely for a lot of these cases, and with a limited degree of aggressiveness, I would say. I tend not to use angioplasty balloons. I think those have a higher rate of causing some damage to the artery that ultimately will lead to rupture when you're putting in your large devices. But the Cook dilators can gently dilate a lot of these iliacs, provided the degree of calcification is somewhat minimal. For conduits, generally you can do these through an oblique retroperitoneal incision with minimal morbidity. I'd recommend no smaller than a 10 millimeter graft. The same is true for endoconduits. We've discussed that a little bit already today. Endoconduits, some people like them, some don't. I've had some trouble using iliac conduit or endoconduits, and again, the smallest diameter I would use is a 10 millimeter Viabon if I was going to do that. There also is an option of putting on direct aortic conduits, or even in the infrarenal aorta, or even the thoracic aorta in some cases. And this is an example of a 10 millimeter aortic conduit sewn onto the aorta itself. In terms of preoperative preparation, obviously imaging is key for these procedures. If your imaging is good and your plan is good, your case generally will go well. CT angiogram is the first step in terms of imaging. Often we use reconstructions either with M2S, TerraRecon, or Cyrix, the Mac-based software. And the issues you want to look at, or parts of the imaging you want to look at, are basically the diameter of the proximal and distal seal zone, as well as the length of your seal zones. Adjusted centerline measurements. A centerline by itself can be helpful for diameters. If you're doing fenestrated work, then obviously the adjusted centerline is important because your wires will lay in a different position than the centerline that is determined by the software. This shows an example of assessing the proximal and distal seal zone, getting diameters there. This is obviously, I would say, a fairly straightforward repair in terms of the aneurysm itself. You also want to assess on your CT angiogram and the reconstruction the iliacs, both the degree of tortuosity as well as calcification and occlusive disease. And then oftentimes we'll use IVUS intraoperatively as well. And the advantages to IVUS is you can precisely measure aortic diameter. This is even more important in ruptures or trauma patients who have maybe a CT scan when they're before they get volume resuscitated, and the diameters can change dramatically after resuscitation. Assessment of iliac axis can also be helpful with IVUS. And when you're dealing with dissections, I think IVUS is essential to make sure you're in the lumen you think you are, the true rather than false. Steps are fairly straightforward: preoperative planning, femoral access of some sort, arch aortogram. This is best done in a steep LAO projection to really open up the aortic arch and make sure that you're seeing the arch in the best profile with the origins of the arch branch vessels clearly delineated. Then we typically will use a curved Lundquist wire put deep up to the aortic valve, and often we'll use an intravascular ultrasound to precisely note our origins of the arch branch vessels and further assess the proximal and distal seal zone. Stent graft is then deployed, and then post-implantation balloon angioplasty is performed to help wall up position, except in cases of dissections or traumatic transections. This is an example of a typical case. This is a 69-year-old male with a prior history of abdominal aortic aneurysm, hypertension, coronary artery disease, and peripheral arterial occlusive disease. who has had hypertension and moderate back pain, unclear whether it's related to his aneurysm or not. But his aneurysm is over 6 centimeters in diameter, so it certainly warrants repair, and just based on size alone. This shows the assessment of diameters using the M2S software of the proximal seal zone, where we're getting measurements between 31 and 35 millimeters, and then the distal seal zone a little bit larger, 36 millimeters. And so the issues here is that, number one, there's a fairly large degree of coverage. The patient has a concomitant small aortic aneurysm infrarenally. These are all potential issues for spinal cord ischemia. Some degree of calcification in the iliacs and somewhat small iliacs, although not too bad. And then some thrombus within the proximal and distal seal zones, as you can see. So those are the sort of challenges. Doesn't necessarily mean this can't be fixed endovascularly, but these are some of the issues you need to think about as you're moving forward with repair. So the good thing for this patient, he has a large, long proximal seal zone distal to the subclavian, so there's plenty of real estate there, as well as a decent seal zone distally, despite the somewhat diseased nature of that seal zone. So this was treated with a 40 millimeter graft proximally and then flared out to 44 distally, total coverage of about 200 millimeters. With a preoperative spinal drain because of some of the concerns with paraplegia. Post-procedure follow-up, most of our patients are discharged home on the first day post-op, provided there are no spinal cord issues or access site complications. Most often I'll get a CAT scan within 30 days to assess the integrity of repair. Type 1 endoleaks are things you generally will see intraoperatively, but sometimes can be missed. So I think it is important to get an early post-op CT. And as long as this looks okay without any evidence of endoleak, you can generally follow these on a yearly basis. More aggressive imaging may be warranted for visualized endoleaks. And each of the IFUs delineate some follow-up algorithms as demonstrated here. Some of the pitfalls with TEVAR include sizing errors. Both undersizing and oversize can really have some serious consequences, and I'll get to that in a second. Insufficient length or quality of the chosen seal zone is going to be a risk factor for failed durability long term. And then not placing endograft proximally up, again, compromising on your seal zone because of concern about dealing with the arch branches vessels. And then failure to anticipate access issues or other preoperative complications that I already highlighted. This is an example of a 32-year-old trauma patient I treated with an aortic transection, and this was a few years back before we had more conformable devices and small diameter devices. So this patient was treated with an excluder, which was a little oversized, or I'd say significantly oversized for his aorta because of two issues. Number one, young patients tend to have small aortas, and they also have fairly tight aortic arches. And so the initial CAT scan demonstrated here showed a little bit of bird beaking, but it wasn't bad, but on further follow-up, this had increased degree of bird beaking, and this patient basically at risk of having a stent graft collapse completely. And so this patient underwent a Palmas stent of that proximal aortic proximal seal zone with rapid ventricular pacing, which is really the only way I tend to put these Palmas stents if and when I have to do this, which has been luckily rare. And this shows the graft tacked down with a Palmas stent. So the concern, obvious in this patient, he's a young patient. This is someone who has many more years ahead of him, who has potential for problems from the stent graft. So. Great vessel involvement, most commonly involved vessel is obviously the subclavian. Most patients can tolerate coverage without preoperative revascularization. SVS guidelines suggest routine revascularization, elective repairs, and expectant ones for patients on emergent basis. Exceptions to this include prior CABG with edema, dominant left vertebral or a vertebral arising from the arch. Options for postoperative revascularization include carotid subclavian bypass with prosthetic. Let me just jump ahead here. So option for zone 1 involvement. Sorry, I skipped. So zone 0 is the carotid subclavian bypass with prosthetic or subclavian transposition. When we move forward to more proximal seal zones involving zone 1, basically extra anatomic bypass. Most of us will deal with these. Followed by a stent graft over the area of the aneurysm. So this is a patient with a common carotid to common carotid bypass followed by a subclavian transposition. Other options for repair include total arch debranching for zone 0 involvement. This is an example of an ascending bypass to the innominate carotid and subclavian. This is done through median sternotomy followed by branch grafts to the rest of these. There are some open fenestrated, custom-made fenestrated options, which I'm not going to go into as far as the arch here. And then suffice to say, in the future, I think we'll have better options for dealing with some of these great vessel involvement problems, such as the Gore-CTAG thoracic branch, the Mona Lisa device by Endologics, which is listed. I guess I lost that somewhere, but that's the Mona Lisa device. So there are some devices which are currently under study and will be entering clinical trials soon. And then as we go more proximally into the ascending aorta, there are some research devices such as the Cook aortic branch device to deal with actual ascending aneurysms and true arch aneurysms. These are obviously going to be a long way off. We've dealt with some thoracoabdominal aneurysms using custom modified or physician modified stent grafts, where we create devices similar to the research devices. This is an example of a patient treated with basically a paravisceral aneurysm by making two renal fenestrations, an SMA fenestration, and a celiac scallop. Start off with percutaneous access. We generally will use an axillary conduit so we can put all of our stent grafts through the fenestrations into the target vessels from the proximal end. This shows the device in place after each of the target vessels have been cannulated with sheaths to mark their position as we deploy the graft. We then partially deploy the graft, and then coming through the top of the partially deployed graft to access each of the fenestrations and each of the target vessels. Once we have our sheaths in place and our stents in place, we then further deploy the graft, balloon the proximal seal zone, deploy our stents within the target vessels, and that's the completion angiogram. These patients, typically, if things go well, always look better than the surgeon does the next day. This is a patient 1 day post-op, 4-hour procedure time, extubated in the cath lab, and home the next day. So this is dramatically different than an open thoraco. Moving forward, we hope to go away from these physician-modified devices. This is the Cook fenestrated thoraco device. Probably won't be the one that goes to market. This is likely to be the one that will eventually come to market. This is the thoracic abdominal aortic aneurysm branch device, which has a permanently constrained central portion with downward branches. And the nice thing about these devices, you can continue to perfuse the aorta through these branches as you're selectively cannulating each one of them, rather than having to get all your branches cannulated in a fenestrated device. So in conclusion, I think that these devices have already helped with a lot of descending thoracic aortic pathology, and as we move forward, we're going to probably have a lot more options because of increasing technology and skill set. Thanks.
Thank you.